Hi, my name is Catherine Coombs. I'm at the University of California, Irvine, where I'm an associate clinical professor. My clinical expertise is primarily in CLL. However, at this year's AACR meeting, I spoke about another interest of mine, which is clonal hematopoiesis as a precursor to leukemia, but also specifically focusing on the role it may play in solid tumor microenvironment. So the research examining the impact of clonal hematopoiesis in solid tumor patients is pretty broad, and I think the main message is that the effect of clonal hematopoiesis in individuals with solid tumors is highly context dependent. And so I think we have seen both in laboratory and clinical studies differential impacts, both in the murine models that have been developed, but also in the subsequent effects on clinical outcomes. And so I think a lot more work is needed to be done, but it will largely depend on who the patients under study are, what therapy they're getting, in addition to which mutations they have underlying, because it seems that all of these can have very differential impacts on the downstream consequences. You know, as far as the next big question in clonal hematopoiesis, it's definitely hard to narrow down to one, but I'll just highlight a specific interest of mine, which is the impact of clonal hematopoiesis in men with prostate cancer. So I shared some work that myself and collaborators have done looking at clonal hematopoiesis in men with metastatic castration-resistant prostate cancer, where it doesn't seem to have a negative impact on overall survival or PFS, given that most men succumbed, unfortunately, to their prostate cancer in under 3 years. However, what we did see is an increase in the risk of cardiovascular AEs for patients with large size clones, variant allele frequency over 10%, but also TET2 mutations. And so my dream of a next study is actually to take this then into earlier stages of prostate cancer, where these cardiovascular AEs may actually mean a lot more for the patient, knowing that actually cardiovascular disease is the #1 killer of men with prostate cancer, which is largely reflective of the fact that it's often diagnosed so early, but patients do still get exposed to androgen deprivation, and I do worry that there may be a potential additive effect of the presence of a mutant clone and the already well-known cardiovascular AE profile of androgen deprivation. I would say another frontier in the world of clonal hematopoiesis is whether there are any interventions that can change the natural history. And so this was actually focused on a bit more by one of the other speakers in my program, Dr. Kelly Bolton. But I think one of the key things that we have to keep in mind when we're thinking of any interventional trial is that #1, clonal hematopoiesis is very common, but 2, the patients that develop severe adverse consequences, such as the development of subsequent myeloid neoplasms, are pretty small. And so I think we as a field just really need to focus in on who are the highest risk patients, which is why I think these risk scoring scales, such as the CHRS score, are so impactful. But then when we think about applying therapies, we have to exert an extra layer of caution, because again, these are healthy people. These patients don't technically have a disease. And so, I think the mantra in all of medicine is do no harm, but I think that's particularly important when thinking of different interventions that we can apply to change the natural history if we can at all.